Welcome to my presentation on peripheral nerves. So originally I was going to just do a PowerPoint presentation, maybe a couple of videos, but I decided maybe I'll just record the whole video and then show you some techniques on peripheral nerves just because the material is pretty dense. So welcome to my video. I hope you are all sitting nice at your desk right now. My name is Erica. I am a physical therapist. So welcome. We're going to get started. The focus of this video is mainly for the subacute type nerve patient, or maybe someone that's had nerve pain for a long time, or just like that tugging feeling. When it comes to very irritable patients, I actually treat that a lot differently, but that's another video for another time. This video is also made for the medical professional, so if you are not a medical professional, please seek medical treatment as well as maybe your local physical therapist. My goal of this video is just to share some tips and tricks of what I've learned over the last few years, especially working in the spine center. I would say peripheral nerves are some of my most favorite body parts, minus the thoracic spine. There is the power of recognition and the power of just seeing something over and over and over again. I'm hoping to share just a few testing techniques, how you can tension the nerve, how you can slide it, how you can soft tissue it as well. So I'm really hoping this is helpful for you all. The best thing you can do is just to make sure you really understand your anatomy, because at the end of the day, if you understand where those nerves are coming through, they're traveling through muscle, fascia, joints, right? Bone tissue. And I would say if you really know your anatomy, you'll know where to reduce that entrapment site, and then you can also help educate the patients. If you need a really good app to show your patients for education or just for yourself for some review, I would definitely highly recommend getting Essential. Oh, this is my home screen, but I will show you right here. And then you can just show the patient on multiple select, like this is where your nerves are traveling through. You really need to make sure you're doing your exercises, because no matter how many medications you take or how many epidurals you have, if you just need to reduce the tissue entrapment site, then you just gotta reduce it. We all know that muscles are kind of more like elastic. They do stretch, right, to a certain extent. When it comes to nerves, nerves are more like, I like to say like cell phone cable. There is a little bit of stretchability to it, but the nerve is not going to move as much as the muscle. So nerves, you really have to think of it like sliding. You're going to slide side to side. If you're trying to stretch a muscle, stretch, or give someone a hamstring stretch for like a sciatica type pain, if they have a tighter restriction site somewhere else, like maybe an entrapment site, you're not going to get the patient much better, and they're going to feel tugging, and it's going to be painful and irritable. Possibly. I like to think of the nerve kind of like the 405 freeway. So let's say you have rush hour traffic at 5 p.m. You have, let's say, 5 traffic stops. You have car accident 1, 2, 3, 4, 5. Okay? So this is entrapment site 1, 2, 3, 4, 5. Lumbar spine, you have the piriformis, biceps femoris, medial to it, the tib-fib joint, and then the dorsal digital nerves on the foot, which are all the peripheral entrapment sites for the peroneal nerve. Just because you PA the lumbar spine, you're still having 4 other traffic stops. So that's like saying rush hour traffic is going really slow. You got rid of 1 car accident, you know, they cleared that up, but still we're getting stopped up along the way. Reducing all 5 traffic stops is going to be the best way to go. But first you have to assess that. It's also really important to take a look at posture. I've treated a few sural nerves just because their lateral calf was a lot bigger than their medial calf, and it was because of the way that they were walking and like the type of shoes they wore. So when I reduced the sural nerve entrapment, they actually felt a lot better at their lumbar spine. For our nerves, we are given what we're given, right? So if you have the nerve and it's trying to move throughout the body, right, because it's like that cell phone cable, you're going to have to assess the neck, the cervical spine, the thoracic spine, lumbar spine, through the pelvis, through the muscles, all the way down to the upper and lower extremity. The spinal canal is 7 to 11 centimeters longer in lumbar flexion versus lumbar extension. When you're going into lumbar flexion, you're putting a lot of tension even in that dura and that fascia. So that is what the straight leg raise test is for, and the slump test. You also have to take into consideration the fascia in the skin. So right through here, you have a lot of little fibers. I like to think of them as layers of spider webs. So if the nerves, like the peripheral nerves and maybe the superficial nerves, are just going through the fascia, also taking a look at how the skin is moving and how the muscles are moving underneath that are going to be really great. So there are 2 main tests you can do for the lower body when it comes to peripheral nerves, and that's the straight leg raise, and that is also the slump test. So my favorite is the slump test just because it's harder for the patient to cheat out of it. I do the straight leg raise test if someone has more pain with walking or they have more of a standing job, because the straight leg raise is more of an extended lumbar spine. If someone has a sitting job or they're having pain with driving, I tend to go more towards the slump test. When it comes to the jargon between a tensioner and a slider, tensioner is where you take the whole nerve and you're going to tension it, the whole thing, and not have any slack. When it comes to the slider, you're going to release one part while tensioning the other. Before doing any neurodynamic tests, such as the straight leg raise or the slump test, be sure to complete a neuroscreen as well as any necessary mobility assessments. Always ask the patient if they feel any symptoms as you take them through each of the movements. Some common nerve description words are numbness, tingling, prickly, pulling, tightness, achiness, deep aching, restriction, burning, lightning, shock, shooting, electric, tugging, deep headache, restless, dullness, and constricted. I'm now going to show you some slump tests for each of the nerves, but before I go through each test, I'm going to show you the entrapment sites. The sciatic nerve can get entrapped at the lower lumbar spine piriformis between the sciatic notch and ischial tuberosity and the hamstring muscle. For the slump test, you want to first start off with putting their hands behind their back and slouching them. I say, please give me really bad posture. Make sure their head stays up as well. You're going to then cervical flex them, making sure they don't go into any extension in their lumbar spine. Raise up the other leg, and then the other leg, and ask if they're having any symptoms. Take a look at how those nerves go through the lower leg, because we're going to tension that with an ankle bias in the slump test. For the peroneal nerve, what you're going to do is you're going to do the same thing where you slouch them, don't let them come up. Now you're going to put them to cervical flexion. Go ahead and internally rotate that femur, plantar flex, and invert that foot. I'm going to go through and just see if you're feeling any of the symptoms. For the peroneal nerve, you want to make sure you really emphasize that femoral internal rotation and ankle plantar flexion and inversion. Skipping this step will cost you some very valuable information. The tibial nerve runs posterior to that calf, medial to the ankle, and underneath the foot. For the tibial nerve, you're going to want to move that ankle into dorsiflexion and eversion. You can wind them up as much as you want with lumbar flexion, thoracic flexion, and cervical flexion, but the bias comes at the ankle. The sural nerve goes lateral to the Achilles tendon, around the ankle, and towards the side of that foot. For the sural nerve, you're going to put that ankle into dorsiflexion and inversion. If someone is irritable, you don't actually have to put them into full lumbar flexion. You can actually just extend that knee and add the ankle bias. Now we will move on to the straight leg raise. For the straight leg raise, I don't tension it at first. Instead, I just pull them up into hip flexion, making sure their knee is extended. If there aren't any symptoms, I will then pull them into ankle dorsiflexion. I also don't really do the cervical flexion or lifting up their own head because there is a lot of bias when it comes to tensing the abdominal muscles. The peroneal nerve straight leg raise involves inversion, plantar flexion, internal rotation of the femur, and adduction of the femur. Depending on where they're feeling their symptoms, you're going to release the tension 2 joints away. So if she's feeling it in her lumbar spine, you're going to release it at the foot. This is another handling technique for the peroneal nerve. It's really important that you don't lose that knee extension, so have your hand or forearm there at the knee to block. For the tibial nerve, you're going to dorsiflex and evert that ankle. Block the knee from extending with your forearm. Here's another view of the tibial nerve straight leg raise where I am taking the toes and I'm extending them fully to really tension that tibial nerve. Here are a couple handling techniques for the sural nerve, which is biasing the ankle in dorsiflexion and inversion. Always make sure to protect your own posture and to use good body mechanics. For the sake of time, I'm going to show you some of my favorite exercises for the peroneal nerve, but you can take the same ideas and apply it to the other nerves as well. To create a nerve tensioner, you're going to lumbar slouch them, thoracic slouch them, and cervical slouch them, and then you're going to extend that knee and then add the ankle bias, so in this case the peroneal nerve. You're going to have them extend and flex that knee to make that tensioner. To create a slider, all you do is just keep them still wound up in that lumbar flexion, thoracic flexion, and then as they kick their leg up, they're also going to extend their neck. So I like to call this exercise, kick your head off. Because sliders will tension one side while releasing the other and vice versa, the tensioner itself is actually used more for higher level patients. So I would always start off with a slider first before a tensioner. You can do different variations of sliders and tensioners, such as just extending the knee and adding the ankle bias. If that's too much, you can actually just do lumbar slouchers in sitting, so like a sitting cat-camel exercise. You can keep your head up, extended, or you can pull it down into cervical flexion. Just make sure to monitor the patient's symptoms with each movement. For the peroneal nerve, there are many entrapment sites, such as the proximal tib-fib joint, as well as medial to the biceps femoris. The peroneal nerve goes down the lateral part of the ankle and then over to the dorsum of the foot. So don't forget to check in the dorsum area of the foot because those superficial nerves can go through the toes and tendons. By reducing the entrapment site here at the dorsum of the foot, you can get a lot of patients better and even feeling better proximally. You can even add a soft tissue technique while the patient is going into plantar flexion and inversion. Add a toe flexion stretch to get even more mobility towards that peroneal nerve. To make it more difficult, you can even add toe flexion, plantar flexion, inversion, and then extend the knee, and then also internally rotating that femur, so you're winding up the tissue distally to proximally. For the patient, they can even do their own stretch into plantar flexion and inversion by pulling up their own ankle. They can add a toe flexion here to make it more difficult. They can also do a soft tissue massage technique to the dorsum of the foot by using their hands, or they can use their heels in sitting. To focus on the entrapment site medial to the biceps femoris, they can put a tennis ball or lacrosse ball underneath their leg. The patient can put as much pressure as they want through that ball by putting their hands on their thighs and rolling their leg back and forth. To make this exercise harder, they can even add knee extension. If someone is very irritable, you could take the back of your hands and just massage the skin. You can also mobilize the nerve by doing a long, soft tissue mobilization swipe. This is another way you can tension that peroneal nerve, but more in a neutral lumbar spine. Now we move on to the femoral and saphenous nerve testing. The femoral nerve originates from L2 through 4, and you can feel it through the tissues at the inguinal ligament. My favorite way to test the femoral nerve is to have the patient in prone. I will flex their knee and then plantar flex their ankle and ask them where they're feeling the symptoms. You can also put the patient into prone on elbows position and then do the same exact thing with their knee and with their ankle. If you need to, have them look up to the sky and see if they're having any symptoms in the thigh or in their back. You can release the tension by having them look back down, or you can release the foot, you can release the knee, have them back down flat instead of being prone on elbows. You can make it harder by having their leg up on a pillow so they're more into hip extension, and then have them prone on elbows and then looking up towards the sky. This will give a lot of tension into that femoral nerve. You can also put your leg underneath their leg if you don't have any pillows. For their home exercise, they can take a dog leash or a yoga strap and pull their knee into flexion. From here, the patient can do a variety of stretches, which includes just looking up and down. They can look up and down at the same time while moving their leg into flexion. There are many variations the patient can try to make it harder. To make it easier, you can just have the patient lay completely flat and then use the rope or the leash to pull their knee into flexion. You can wind up the tissue even more by putting the strap on their toes and then pulling into plantar flexion and knee flexion. For the saphenous nerve, take a look at how it goes underneath that patella. Be sure to ask if there's any history of knee surgeries or injuries. For the saphenous nerve, you're going to do the same thing, except for you're going to abduct that femur, as well as internally rotate the femur to spiral that saphenous nerve into its tensioned position. Make it harder by going prone on elbows or looking up towards the sky. Add a yoga strap for their home program. Get creative with their home exercise program and create for them sliders and tensioners. Knowing your anatomy, you can create any exercise for any nerve. Next, we will go over some spine and hip mobility exercises that are really helpful when it comes to the peripheral nerve. One option of stretching is putting the patient in a quadruped position and just going into cervical flexion and extension. You can also add a lumbar flexion, like a cat-camel type of exercise, making sure to really get into that good range of lumbar flexion. So pull them all the way up and see that nice curvature. You can also add cervical flexion to this when they're going into lumbar flexion. Once they are in that lumbar flexion position, you can also move them into a child's pose. This is going to give a really good stretch to that dura. Add cervical flexion if you want to make it more difficult. To add variation, put the hands on the left and feel that stretch on the right. You can add more stretch by giving a soft tissue mobilization technique at the same time. To bias more of the thoracic spine, move the hands closer towards the knees and then have them go into thoracic flexion. You can add cervical flexion into this as well, but really emphasize that thoracic flexion. Bring them up all the way so they feel the stretch between those shoulder blades, and then they can go back down. To make it more difficult, go into the child's pose stretch. In the hook lying position, you can take a tennis ball or a lacrosse ball and put it on a painful spot or just an area that needs more mobility. I then have the patient rock side to side, about 30 repetitions per painful and stiff area. Using the tennis ball is completely optional, but it does help get some more increased mobility. If there is too much pain going towards the painful side, then you can always go away and then back to the center. You can also do this exercise without a ball and just move the cervical spine with the lumbar. So when you look to the right, move the legs to the left, and when you move to the left, move your legs to the right. This is called wringing the towel. For hip and glute mobility, you can bring the knee towards the chest and hold it. You can also bring it across your shoulder, and then add variation by pulling the ankle, bringing up that other leg, pushing the other knee down, or pulling it across the body, and then you can pull it up to get that nice piriformis stretch. These are some good in-bed options. For more piriformis mobility in a sitting position, you can have them sit in the figure 4 position and lean their chest forward. If this position is too strong for the patients, they can actually take their hands and place it behind them. To get that psoas or hip flexor stretch, you can get into the lunge position. However, be careful not to lumbar extend too far. Bring that knee underneath the shoulder, and then you're going to put the pelvis into a posterior pelvic tilt. This will let you get some stretch at the psoas while keeping the lumbar neutral. For more lumbar mobility, you can also slouch as much as you can, kind of like that slump position we were doing earlier. Bring the chest towards the legs. Normally their feet would be on the floor. You can go to the right, and then you can also go to the left. This is a really good low-level exercise, and you can do it throughout the day. To get more thoracic flexion mobility, you can do bear hugs. So take your hands, put them on your chest, and go ahead and squeeze those elbows together. Even though you can add cervical and lumbar flexion, really emphasize that thoracic flexion as you go down. Another great bed exercise is the open book, where you get thoracic extension and rotation. This one will also give you a nice chest stretch. If you want to, you can also put that bottom leg down, and then you can do the open book. The skin and fascia through the spine and also the muscles can influence how nerves move, so you can always take the skin and pizza roll it for treatment. Doing a posterior-anterior mobilization to the lumbar, thoracic, or cervical spine is always helpful. This is where you can get a lot of increased mobility. If the patient is higher level, you can prop them up on their elbows or put them in a prone straight leg raise. Now we will go over median, ulnar, and radial nerves. It is normal for the patient to feel pulling, tugging, prickling feelings, as well as numbness, but ultimately we are looking for their exact symptoms. Take a look at the anatomy and where the nerve spirals down in the arm all the way down to the fingers. We're going to tension this in the next test. For the median nerve, I'm going to show you a quick screen followed by a supine test. If the patient is having any symptoms with any of these movements, then you may want to examine in the supine position. To get a quick tension of that median nerve, stop, turn, and swing, and then assess for symptoms. For the median nerve, you can take the patient into abduction about 90 to 110 degrees and then put them into external rotation. Do not depress the scapula. You can then supinate the forearm, wrist, and then get some finger extension. You can then bring them into elbow extension, but make sure you assess their symptoms throughout the movement, as not everyone can get to the full range. You can further sensitize this test by having cervical side bend to the right or left. Be sure not to place your elbow in front of their shoulder, and don't lose any of the shoulder abduction, wrist extension, or supination when you're extending the elbow. When it comes to the entrapment sites of the ulnar nerve, take a good look at the elbow and all the muscles, fascia, and tendons. For a quick tension of the ulnar nerve, drink a British teacup and pour it on your face, and look for symptoms. For the ulnar nerve, you're going to start with shoulder depression, and then abduction of the shoulder, and then external rotation separately. You are then going to pronate their forearm, and then get some wrist and finger extension, flexing their elbow to see if there's any symptoms. Be careful not to pull on the pinky too hard, as most people will feel pain there. Another way you can tension the ulnar nerve is by putting their elbow close to your ASIS and depressing the scapula. Then you can put them into external rotation of their shoulder, pronation, and then finger and wrist extension. You can then sensitize by abducting their shoulder some more. Be sure not to lose the scapular depression or the shoulder external rotation when performing this test. Because the radial nerve spirals around that tricep area all the way to the forearm, make sure you do a good palpation at each of the entrapment sites. For the radial nerve, put your thumb in your fist and sword fight. Make sure you internally rotate. Stab. For the radial nerve, have the patient lay at an angle so you can depress that shoulder with your thigh. Now it's really important to make sure you get full internal rotation of that humerus and full pronation of that forearm. Keep that elbow extended, flex the wrist and fingers, and then you're going to abduct that shoulder, looking for symptoms. Release the tension 2 joints away from where the patient is feeling the symptoms. Doing anterior-posterior mobilizations at the cervical spine is another way you can test or assess for radicular symptoms. Now we will go through treatment for median ulnar and radial nerves. For the median nerve slider, you can do waiter, come. Normally the slider is done at the side of the body, but if that is too provocative, you can always bring the shoulder into less abduction and less flexion. If you understand the anatomy of the nerve and where the entrapment sites are, then sliders and tensioner variations can be endless. For the ulnar nerve, you can do a slider, snake, stop, snake, stop. And if that is too provocative, you can bring it down into less abduction, or you can move the arm in front of the body. Play around with the wrist extension, abduction, external rotation to create sliders and tensioners. For the radial nerve slider, you can do bowler, track baton, bowler, track baton. Make sure you get that internal rotation when you're reaching for that track baton. For all of these exercises, you can always add a cervical rotation or even a side bend. Play around with different segments of the nerve by just tensing up certain areas of the arm. Drop it down to make it less provocative. When it comes to mobility, the patient is going to want to do these exercises throughout the day. When it comes to soft tissue mobilization for the nerve, what I do is put some cream in my hand and go down the entire pathway of the nerve. You can also simultaneously tension the nerve while you're doing that soft tissue technique. I'm demonstrating a soft tissue mobilization for the radial nerve, so I am demonstrating internal rotation of the humerus as well as forearm pronation. Afterwards, I like to follow it up with a few sliders. There are many schools of thoughts when it comes to winding up the tissue here, winding up the tissue there. You got to do it this way, and then this way. But in the end, if the patient just needs flexibility at one spot or more mobility in another, then that's what we're going to give the patient. Ultimately, most of us just need to get moving a little bit more, and depending on the stuff that we do during our day and like the type of jobs we have, that's going to really impact like how our muscles, how our nerves, how our joints feel. So I would say just getting the patient moving is just the ultimate goal. When it comes to palpation, you're going to want to take your hands and make them pretty flat, and you're just going to want to push through. If someone is very irritable, it's actually really important not to push very hard, and you just want to see how the skin is moving on top. It is also really important to take a look at scars. So I had this one patient, and she was like whacked with a helicopter blade, which was crazy, you know? She was whacked with a helicopter blade right across here, and guess what else is also right there? Radial nerve, right? The radial nerve travels right here through the radial groove area. So she had old scar tissue through there. So just working on the skin and pulling it up was actually one of the treatments, and she did get a lot better. Check for shark bites, window glass cuttings, right? Which these are all true stories. I've had patients like this, but ankle fractures, wrist fractures, maybe any type of surgery is really important to ask that patient, just because if we're looking at that full 405 freeway, right, there can be entrapment sites just even through the skin. So just make sure you cover your bases. When it comes to patient education, I do emphasize that nerves do take longer to heal, so it's not going to heal normally as quick as muscles, and normally I say it's because the nerve is very intellectual tissue. Not saying that the muscle's dumb or anything, but you know, the nerve does tell the muscle where to go, so the nerve is more the head honcho. There are a few key things that you need to make sure the patient understands in order to get better, and that includes the exercises need to be done as prescribed. Also, pushing harder to provoke pain will not speed up the process. Exercises need to be done correctly, and mobility should be done throughout the day. It's like brushing your teeth. If you wait for the end of the week to brush your teeth for an hour, that's not going to benefit you as much as brushing your teeth 2 or 3 times a day. As far as it goes for getting improvement, the location should be getting smaller, the symptoms should be less frequent, intensity should be lower, and activities should be feeling better, such as being able to do X amount of activities for X amount of time. Also, when they're doing their stretches, they should not be pulling to the point where they want to throw up or there's a lot of pain. I normally say just try to feel just a little bit of pulling, maybe about 5 or 10%, but other than that, try not to irritate the nerve, as it is intellectual tissue and it will tell you when it's mad. When it comes to educating my patients on what they can or can't do, because a lot of them still want to exercise and work out, what I normally say is, okay, if someone's having a positive slump test and they're having pain with sitting at their desk, then an exercise like road bike, where they bring their shoulders towards their knees and, you know, they're like in this position, that's not going to be as appropriate for them. So maybe their exercise should be maybe walking or taking a hike. I definitely want to keep my patients moving, so I try to custom tailor their exercises of what they can and can't do. And once you reduce those entrapment sites and you're working on the flexibility of the joints and the muscles, and then you're doing your strengthening after, we're going to get the patient back to what they ultimately were doing before. So we just have to make sure they know to be patient, not to over push it when they're going through your treatment and your physical therapy. Thank you so much for coming to my video and watching, and thank you. I hope you have a good rest of your workday, and maybe do some sun salutations to stretch a little bit more. Okay, bye! Oh, and we also have Tuga here. Say bye! Bye! If you like what you see, please like, subscribe, and click that notification bell for more content.